Thank you so much for taking the time out during a weekday to be here to talk about something that I feel very passionately about. So thank you so much to the Fatty Liver Alliance, and Mike Patel, Cheryl specifically as well, because you know, the amount of work that you've done in just about 4 years, it's remarkable. So thank you for everything that you do and for your advocacy for our patients around the world. So like Mike had mentioned, so today I'm very happy to be giving this talk, something that I feel very passionately about. You know, a lot of the things that Mike said, I'm sure they resonate with a lot of people here. It certainly resonated with me. You know, I come from a family where we have a very significant burden of diabetes, cardiovascular disease, unfortunate young cardiovascular deaths. So that's always something that's been on the back of my mind. I grew up as a very obese child throughout my childhood, and so this is something that is very, very close to my heart. So I'm happy to be giving this talk and answering any questions. So without further ado, here are just some disclosures just to mention before we get started. So I want to tell you what I'm going to tell you, and then I'm going to tell you what I've intended to tell you. So, so we'll talk about defining and the redefinition of fatty liver disease and what the nomenclature is as of 2023. We'll talk about some numbers in terms of how common fatty liver disease or MASLD or MASH is, why it's important from a health impact standpoint, what's the natural history, meaning if you develop fatty liver disease, what's likely going to happen, and how do we diagnose it, and how do we identify those individuals who have the disease who are going to particularly be at risk of having a poor outcome, like an early death or a complication of liver disease, like cirrhosis and vomiting blood and so forth. And then, of course, how do we treat MASLD and MASH in this day and age? So let's talk about what is fatty liver disease. So just on the surface, when you think about fatty liver disease, you obviously think about the accumulation of fat in the liver. Now, essentially, the accumulation of fat in the liver is a response that the liver has to any form of injury. So any kind of insult or any kind of hurt that's happening to the liver can manifest in the form of fat accumulation. Now, as Mike had also mentioned, the liver doesn't usually like having a lot of fat in it, and so that does have downstream consequences. There are many different reasons why you can get an injury to the liver, or why you can have insult to the liver that can result in fat accumulating in it. So one of those is, of course, metabolic dysfunction-associated steatotic liver disease, or MASH, or what we used to call non-alcoholic fatty liver disease. So the colloquial term became fatty liver disease. Alcohol consumption, alcohol is a toxin to the liver. One of the first manifestations is that you can get fat accumulation in the liver. Viral hepatitis or viruses can cause it. Certain genetic disorders and metabolic disorders listed here. Adverse reactions to drugs, like antibiotics, can also manifest, or certain anti-epileptic drugs can also manifest with fat accumulation in the liver. So it's important to delineate when you're talking about the term fatty liver disease, which one are we specifically talking about? So usually when we're using the term fatty liver disease, we're talking about non-alcoholic fatty liver disease. And up until June 2023, this was the terminology that we used. But over the past few years, it had been identified that this terminology is quite problematic. First and foremost, it's, you know, for no reason whatsoever, we have this term alcoholic in it. So it creates this unnecessary stigma associated with the consumption of alcohol. The other thing is that by using the term non-alcoholic, you're creating this false sense of dichotomy, that everything is either alcohol or not alcohol, which is not true. There are many, many different causes of liver disease. And so that was certainly something that was identified as a problem. The third thing is that whenever you start something with the term or the phrase non, automatically it gives it, you know, less importance, that it's something that's not the important thing, but it's non-alcoholic fatty liver disease. So we felt that for something that affects 1 in 3 people worldwide and 1 in 4 people in Canada, you need to give it a little bit more respect. Of course, then when you use the term non-alcoholic fatty liver disease, it doesn't really tell you anything about how this disease develops, what the mechanism is. So they wanted to come up with a term that would explain this. And then, of course, there's the problem that I mentioned, that the term fatty liver disease can potentially encompass or talk about many different things that can cause insult to the liver, but it doesn't really specify that we're talking about the metabolic dysfunction that is associated with it. So then on June 24th, 2023, at one of the European liver conferences, EASL, on that day it was decided that they would launch, after many, many months, actually even years of discussions from people from across 56 countries, over 250 representatives, more than 70 liver societies and patient advocacy groups meeting in multiple places, including a large meeting in Chicago. They came up with a consensus that we need to redefine the way that we think about accumulation of fat in the liver and the whole spectrum of conditions that can cause accumulation of fat in the liver. So they came up with this overarching term called steatotic liver disease. So that literally means fat in the liver. So that is an overarching term for anything that can cause accumulation of fat in the liver, steatotic liver disease. One branch of that is metabolic dysfunction-associated steatotic liver disease, or MASH. So this, which I've highlighted here in the red here, this is what we used to call non-alcoholic fatty liver disease, or non-alcoholic steatohepatitis. So the difference between the two is MASLD, or NAFLD as it used to be called, is just a generic term for the condition in which you have fat accumulation in the liver due to cardiometabolic risk factors. But because over time the liver doesn't like to have fat accumulation, and that triggers inflammation, cell injury, and death, that's when you start getting steatohepatitis, or MASH, or previously called NASH. And then, of course, within that umbrella, you also have liver disease, or fat accumulating because of excessive alcohol consumption. People who have metabolic risk factors but don't drink that much alcohol, they're kind of in this new disease entity that's called MASLD. So you have a little bit of cardiometabolic problems, and you're probably drinking a little bit more than you should, but not as much as what would be considered alcohol-associated liver disease. So you're kind of in this, mishmash of conditions called MASLD. And then, of course, there are many of the other etiologies that I spoke about in terms of Wilson disease, monogenetic disorders, and so forth. But we're going to focus today mainly on MASLD and MASH. So just to recap then, so steatotic liver disease is just fat that you identify in the liver. It could be from any etiology or any cause that you pick up either on some kind of ultrasound or imaging study, or if you, for whatever reason, had a biopsy done and they identified fat under the microscope, that's steatotic liver disease. Metabolic dysfunction-associated steatotic liver disease is fat in the liver due to cardiometabolic risk factors. So that basically means you have certain conditions that increase your risk for heart disease and strokes, and by and large also accumulation of fat in the liver, and no other contributing cause. And then MASH is when you have the presence of MASLD, but you also have inflammation and cell injury because the liver doesn't like to have fat in it for a long period of time. So for all intents and purposes, fatty liver disease, when you're talking about it, is MASLD or MASH. So let's talk about how common is MASLD in Canada. So when you talk about epidemiology, you're talking about what's the distribution of the disease in Canada, what are the causes of the disease in Canada. So approximately 1 in 4 Canadians, and this is probably an underestimate if I was to mention, because this is data from around 2019, 2020, 1 in 4 Canadians has MASLD. And it's thought that by the year 2030, this number will at least increase by about 20% or so. And by the year 2030, there'll be a doubling of the number of people who have MASLD who will pass away from liver cancer, cirrhosis, or extensive scarring of the liver, or will have death as a result of MASLD in itself. Why is it important? Why do we care about MASLD? Of course, it's a problem associated with the liver, but not a lot of us really know is that the number one cause of death in individuals who have MASLD is actually heart disease and strokes. So heart attack, strokes, mini stroke, heart failure, deadly heart rhythms, these are actually the number one cause of death in individuals who have fatty liver disease. And then, of course, it's important because fatty liver disease can result in accumulation of inflammation, cell death, and over years and years of inflammation, cell death, and turnover, the liver finally says, why do I keep regenerating these cells in the liver when they're just going to die? I'm going to start replacing this with putty, or replacing it with fibrosis or scar. But scar tissue does not have the same function as a regular liver cell. Liver cells do over 200 different functions. If you just fill it with just some cement or just some scar tissue, it's not going to have that same functionality. If you replace the entire liver with just scar, then you get cirrhosis or end-stage liver disease and a lot of complications that ensue. And a lot of us don't really talk about it, but MASLD has also been associated with an increased risk of cancer. not just liver cancer, but a whole host of other solid organ cancers that we previously did not know about until about 2018 and 2019. And I'll share some of the data with you today. So when we talk about the natural history, so if you do develop fatty liver disease, what's the likelihood that you're going to progress, and how are you going to progress? So if you start off with a healthy liver, just in the general population, about a quarter of individuals are going to develop MASLD or just develop fat accumulation in the liver. 1/5 of those individuals will have significant enough inflammation developing and cell injury developing that they will develop MASH, or steatohepatitis, or metabolic dysfunction-associated steatohepatitis. Now, with inflammation, you start to begin accumulating scar tissue, and that can be in various different grades that we'll talk about. And if you replace the entire liver with scar tissue, you'll develop cirrhosis, and that's about 15 to 20% of people who have MASH. So a quarter of the population will have MASLD, 1/5 of those will have significant inflammation and scar, and about 1/5 of those, or 15 to 20% of those, are going to develop extensive scarring of the liver, which increases your risk of really, really terrible outcomes, including vomiting blood, accumulating fluid in the abdomen that may require you to have paracenteses or needles poked in your abdomen to remove fluid on a weekly or biweekly basis, increases your risk of liver cancers, increases your risk of confusion and neurological complications because your liver's not working well, which we call encephalopathy. So just to explain in terms of when we look at it under the microscope, the amount of scar that you have in the liver is typically graded from 0 to 4 or from 1 to 4. So and the critical threshold is when you reach that level of a stage of 2 out of 4. So that's when you have significant scar that you're likely going to progress. And when you have stage 3 or F3, that means you have an advanced level of scar. And when you're at stage 4, that means you have cirrhosis or full and extensive scar in the liver. Like I mentioned, it's only a fraction of individuals who are going to progress, but when you identify someone who's already at the F2 stage, by and large, you're more likely to progress on to developing cirrhosis if you don't do something about the disease, as opposed to if you're in the F0, F1 stage. So it's important to understand it's not just a number, but it has implications in terms of outcomes. So why does scar tissue matter? So obviously, like if you theoretically think about it, your functioning cells are being replaced by scar tissue, but it's also been shown in multiple studies that in a stepwise fashion, the more scar you accumulate, the higher chance you have of dying from liver disease, and the higher chance you have of having some of those really, really dreadful complications that I spoke to you about. This is an important paper by Aaron Samuel's group that identified that. So it's the most important prognostic factor in patients with MASLD is how much scar you have, or if you have scar at all in the liver. Who's at risk of developing MASLD or fatty liver disease? And these are individuals who have cardiometabolic risk factors. So that means you have a condition that increases your risk of developing plaque in your arteries, which increases your risk of heart attacks, heart failure, and strokes, and the liver is an innocent bystander of that process as well. So these conditions generally are diabetes or prediabetes. So prediabetes means that you haven't developed diabetes yet, but if you don't do something about it in terms of weight loss or exercise, you're probably going to go on to develop full-blown diabetes. If you're obese or overweight, and we usually use BMI, it's a very crude and flawed cutoff to use it, but that's what we generally use to determine BMI, and it's different for people of Asian ethnicities compared to those who are non-Asian ethnicities in terms of risk. If you have high cholesterol or dyslipidemia, so if you're on a medication like atorvastatin or that's high cholesterol, or if you have high blood pressure. These are the 4 main cardiometabolic risk factors. Probably the most important are diabetes and obesity, just in terms of the intensity with which they are associated in almost a 2-way direction with fatty liver disease. And the general consensus from most of the societies, whether they be liver societies in the US or in Europe, or in Canada, or whether it be diabetes societies within North America or Europe, have diabetes or prediabetes, if you're obese, or if you have any of the other 2 cardiometabolic risk factors, you should probably be screened, meaning that you should be tested to see if you have MASLD or fatty liver disease or not. So why is diabetes important? So diabetes has a very important 2-way relationship with metabolic dysfunction-associated steatotic liver disease. About 65% of patients, so like approximately 2/3 of patients who have diabetes, have fatty liver disease. 41% of patients who have diabetes already have MASH with significant scar. And individuals with MASLD who haven't developed diabetes have a 2 to 5 times greater risk of developing diabetes in the future compared to individuals who don't have MASLD. So you can see there's a very strong two-way relationship between the diseases, which is why the recommendation is so strong that if you have diabetes, you should be checked for fatty liver disease. And how do we do that? You start off with a very basic study, like an ultrasound of the abdomen, just to see if there's any presence of fat in the liver, and also blood work. So the blood work is typical tests, like complete blood tests, like your hemoglobin, your platelet counts, and so forth. And then liver tests, which include your liver enzymes, like AST, ALT, you may have heard of these, and then liver function tests. So these similarly blood tests that assess how well your liver is functioning. So it's not necessarily the enzymes, but it's things like albumin and bilirubin and so forth. So then how do you make the diagnosis? You've screened someone, you have an ultrasound, you've done the necessary blood work. How do you make the diagnosis in itself? So the diagnosis is usually made after you've had a complete history, physical examination, and a slew of blood work. But the important thing to recognize is that MASLD is a silent disease. Just like high blood pressure, it's a very silent disease, meaning that the vast majority of patients don't have any symptoms at all. So, and a lot of people, they go to the doctor when it's mainly reactionary. Doc, I have a headache. It hasn't been going away. Doc, I fell in a hair. And that's unfortunately the nature of things. You won't really know if there's a problem. And the individuals who do have symptoms, most of them are really, really vague and nonspecific. So fatigue is often a symptom that most people with fatty liver disease complain of, and fatigue can be for hundreds of different reasons. A generalized feeling of being unwell. No, I just feel unwell. That's what we call malaise. And then, of course, in some patients, you can also have this vague, very dull discomfort in the right side of your belly. And that's mainly because with the fat accumulation, the liver's become more plump. It's stretching the capsule that it's surrounded in, and that's causing some discomfort in the right side of your abdomen. But the vast majority of patients have no symptoms at all. So the criteria to determine whether you have MASLD is, so one, you need to have fat in the liver. Second, you need to have at least one cardiometabolic risk factor, so pre-diabetes or diabetes, high cholesterol, high blood pressure, and so forth. You need to make sure that you've excluded other causes of liver fat accumulation, that you're not drinking an excess amount of alcohol, you don't have hepatitis C or hepatitis B, you don't have a genetic condition called hemochromatosis, which is the most common genetic disorder in Canada. So it's important to make sure that all these criteria are being met, and that is something that you would work with your primary care doctor and eventually potentially your liver specialist or GI specialist as well. But certainly something that can be done in your primary care doctor's office as well, or your family doctor's office. So once you've made the diagnosis, you've identified there's fat in the liver, your doctor ordered the hepatitis C, hepatitis B tests, all the other blood work that was necessary to rule out other causes. We've captured on the ultrasound that you do have fat in the liver. We think it's MASLD. How do we manage this condition? So the general paradigm that I pose to most patients, and even when I'm talking to other physicians, is that it's not just about, we think about weight loss is the only thing, but it's more than that, because it is a multidisciplinary condition. It's a multi-pronged condition. It's closely related to your heart, risk of strokes, associated with diabetes, control of blood sugars, control of your lipids or fat, the amount of cholesterol in your body and your blood. So the first thing is to evaluate, like I mentioned, the most important prognostic factor is how much scar you have. So the first thing is to figure out, okay, I have fatty liver disease. Do I or do I not have scar? And how much scar do I have? Okay, that's the first thing. The second thing is that once you've identified that, weight loss is the only treatment that we have, or it's the most robust treatment for fatty liver disease. And I'll go over some of the more plenary data that explains that. And in order to achieve weight loss, you have to start off with the basics: lifestyle modification, diet, and exercise. And we'll go over some of those things as well. The third thing is the driving force behind the development of fatty liver disease, those cardiometabolic risk factors like diabetes, prediabetes, high blood pressure, you have to control them, because those are the things that are driving the accumulation of fat in the liver. That needs to be curtailed. And then vigilance in cancer screening is really important. Like I mentioned, and I'll go over the data, that patients with MASLD have an increased risk for solid organ cancers. It may not necessarily be a Cancer Care Ontario recommendation, but it's important that you're on top of getting your cancer screening done that is age appropriate and gender appropriate. Because we don't have any Health Canada approved therapies as of yet, it's always good to find opportunities through which you can participate in some of these clinical trials in which we are investigating drugs that could eventually get to the finish line and be available for the millions of patients who are present in Canada and around the world who may benefit from this. So, how do you evaluate how much scar you have in the liver? Generally, you have invasive tests and non-invasive tests. So, an invasive test means that you are able to sample a piece of tissue from the liver, and you directly look under the microscope, and the pathologist tells you, yes, there is fat in the liver, likely 33% or between 33 to 66%, but it's invasive. It's problematic. You have a needle that's going in. It doesn't take that much time, but if you can avoid an invasive procedure with its associated risks of bleeding, discomfort, infection risk, potential hospitalization, probably a good idea if you have something that's non-invasive, maybe start off with that. You have blood work in certain combinations, and you use them in combinations to develop these scores that predicts your likelihood that you have advanced scar in the liver. And then you have imaging studies or elastography. And this is basically using certain imaging studies to assess how soft or how stiff your liver is. So if you would imagine, if any of you have been to the butcher shop and seen a liver, or cow liver or lamb liver, it's usually nice and slippery and squishy. But if you have a lot of scar in it, you would imagine that it's hard and rigid. So if you have a technology that can determine how soft and squishy your liver is, that could be used as a surrogate for how much scar you have in the liver. And that's the concept behind elastography. So non-invasive tests are certainly favored, even though the gold standard, as we call it, have been the invasive test of the liver biopsy. Now, within these non-invasive tests, so you have blood work, which are your wet tests, and then you have your dry tests, or elastography, which is that test that determines how squishy or soft or stiff your liver is. And usually, these serum biomarkers, so these are basically scores that you punch into a calculator based on what your platelet counts are, what your liver enzyme levels are, and other things. And usually, these non-patented drugs, you don't really have to pay out of pocket from them. They're very straightforward. There are other tests that are present. Some of them are present here in Canada and also present in other parts of the world. The ELF test is one that has been validated extensively in the literature. It's only available in Canada. You have to pay, I think Life Labs, you have to pay about $275 for it. So it's not really well favored from that standpoint if you have access to a dry test or elastography test. And within elastography, you have things like transient elastography or FibroScan, shear wave, and then a special type of MRI called an MR elastography. These are just some examples. You don't really need to go through this, but you can see the components of these blood-based scores are simply using simple things like your age, platelet count, AST, and ALT, and there are certain cutoffs that can help us determine your likelihood of having advanced level of scar or not having advanced level of scar that can help triage in terms of what your risk is of having a poor outcome. In terms of elastography, so you may have seen this picture. So this is a picture of a FibroScan machine. It's a very simple in-office test that one of your even primary care doctors or hepatologists can do. It's almost like getting an ultrasound done. So the concept behind it essentially is that you'll be in the office. They ask you to not eat or drink anything, ideally for about 2 to 4 hours before you have the test done. And as you can see here, the practitioner, they have exposed the area where the liver is. It's right under the rib cage on the right-hand side. So the patient's relaxing. They have their hand behind their back. So that exposes the rib cage, expands the rib cage so that you can actually use the probe. And you want to go between the ribs because you want to capture what the stiffness is, not of the ribs, because that's bone, they'll be really stiff, but you want to capture the stiffness of the liver. So what's going to happen is that this probe, you apply a little bit of jelly onto it, and you go in between the ribs. Usually there's certain landmarks that your doctor will use, and what it will do is that it will generate a vibratory impulse. So you'll feel a little bit of a tickle as it generates a vibratory wave. That wave is going to propagate through the skin, through the soft tissue, and eventually get through the liver, and it's going to travel with a certain speed. And so what this probe is doing is that not only is it generating that wave, but it's also calculating the speed at which that wave is traveling through all these tissues and specifically through the liver. It will then use that and enter it into a formula for elastography, and that speed will be converted into a liver stiffness measurement. So think about it this way, that if you have a tennis ball and you want to bounce it against the wall, if I bounce it against this wall, the wall is really stiff, so it's going to come right back to me. If I put a mattress up there and I start throwing it against that mattress, it's nice and soft and squishy, it's going to take some time for it to come back, or it may not even come back at all. So using that concept with the speed at which that ball is coming back, or the speed at which that ball is emanating, that will determine, or can be used in a formula to determine how soft or stiff your liver is. That's basically the analogy I like to give. And it usually takes less than 5 minutes to do this. So not to make things complicated, but usually your family doctor will be using some algorithm like this to identify who likely needs to be seen by a liver doctor who has fatty liver disease. So if you have diabetes or pre-diabetes, or if you have multiple metabolic risk factors, they would then screen you with, starting off with some blood tests like the FIB-4, and using those different cutoffs. If you meet that cutoff, that you're likely to have advanced scarring of the liver. It's not a perfect test, of course. Then they would move on to doing some further confirmatory testing, whether it be something like a FibroScan, or they can even do an ELF test if it's available in Europe, or if you're willing to pay over $200 out of pocket. But that's generally a two-step process through which we do things. They've looked at different models through which you just do both at the same time, or you just do the one. And obviously in different health systems, there's costs associated with it, but generally speaking, that's how we do this. So we spoke about the only treatment being weight loss. So how much weight should you lose? Or what is your goal weight loss if you know you have MASLD? So the number we tell everyone is you want to aim to lose around 7 to 10% of your baseline body weight. So if you weigh 100 kilos, let's say, you want to lose about 7 to 10 kilos. And the reason is because there was a really important study that they did approximately 10 years ago where they enrolled patients who were of Cuban origin, and they put them through a program where they were undergoing lifestyle modifications, and they then evaluated with liver biopsies what happened to the liver of these patients with fatty liver disease after they lost 5% of their weight, 7% of their weight, and 10% of their weight. If you lose 5% of your weight, you will see a significant reduction in liver fat. If you lose 7%, not only will you lose liver fat, but the amount of inflammation and cell injury will also subside. And if you lose 10%, not only will you have improvements in fat accumulation, but reduction in inflammation, and also a little bit of reduction in scar tissue. Maybe not completely, but you can see some regression from that standpoint. So that's why we ask individuals that you should aim that your goal should be, and I tell people, reach for the stars, aim for 10%. You can certainly do this. But unfortunately, when you look at this study in itself, this is in a very controlled environment. You have doctors seeing you frequently. What's the likelihood that people are going to be able to reach these goals? It's not easy. I mean, going through this process myself over the past few years, it's not an easy process to, despite all your hard and diligent efforts, to lose weight. So when we looked at the numbers in this study, only about 30% of people in this controlled environment lost 5%. 18% of the people in the study lost 7%, and less than 10% of the people actually reached the goal weight loss of 10% itself. There's actually a very interesting study that looked at just published a few weeks ago, that looked at about 177,000 patients who were obese and overweight in the United Kingdom, and they wanted to see what was the likelihood that these patients, all comers, were able to lose 10% of their body weight. So the numbers are actually a lot less than these were. There was actually 1 in 1,000 patients, 1 in 1,000 men, and 1 in 650 women were able to achieve 10% weight loss. So it's much smaller numbers than this. But you have to start from somewhere. In terms of how to lose weight, you start off with lifestyle modifications, meaning your diet and exercise. That is basically the cornerstone or the foundation of any weight loss plan. If you need a little bit of a boost or supplement, there are pharmacological therapies, some of which are Health Canada approved, some more easily accessible to patients who have diabetes than those who don't have diabetes. And then, of course, you have bariatric interventions, which I won't really go into, but that basically means that you have bariatric surgery or bypass surgery to help you lose weight. So the general gestalt of dietary recommendations, or the general outline is, weight loss from a diet standpoint is simple math. Calories in versus calories out. You want to make sure that the amount of calories that your body is utilizing or burning is essentially going to be more than the amount of calories that you're taking in. And basically, I generally ask patients, just based on international guidelines, that start off with 500 kilocalories. And it's different, and you can use different online calculators. They have some flaws to determine what your caloric needs are, how many calories you need. It's something called the Harris-Benedict equation. And will tell you how many calories your body needs at rest, or if you're very active or sedentary. And based on that, you can determine, okay, my body utilizes this many calories. I should make sure that I'm achieving 500 kilocalories, less than that. To put it into context, if you lose 500 kilocalories per day, and you do that 7 days a week, that's about 3,500 kilocalories. That's about 1 kilo equivalent, okay? So apart from just the simple math of it, avoidance of alcohol is key. Added sugars, like syrups and sugar-sweetened beverages, your colas, your diet colas need to be avoided. Processed foods, like deli meats, cookies, chips, all the things we love, and junk food, that needs to be avoided, of course. Refined carbohydrates, so that basically means you're thinking about like your enriched flours, your pretzels, these kinds of things. Those need to be limited. You want to prioritize proteins, either from animal sources or from vegetable sources, and we'll go over some of those things. Avoiding saturated fats. Fats are good for us. We need fats, but there are healthy fats, and there are some not so healthy fats, and there's some terrible fats as well, which are trans fats. And then any added salt you want to avoid. So if you have metabolic risk factors, you're more likely to have hypertension, so you want to avoid added salt because that can cause additional problems. So the diet we usually recommend in most of the literature is the Mediterranean diet. There's also some data out there on the ketogenic diet, but the Mediterranean diet is something that we have borrowed from our cardiology or heart colleagues that has been shown in the literature to be actually excellent for preventing heart attacks, strokes, and mini strokes. And because it's all part of the same family of things that affects the liver, it makes sense that this would potentially work as well, and that there is a lot of data to support that. So the Mediterranean diet, it's basically a heart-healthy diet, and it's influenced by some of the food that's consumed in the countries that surround the Mediterranean Sea. So the basic concept is you're prioritizing healthy fats in the form of olive oil. You have your fruits and your veggies, whole grains, legumes, beans, healthy nuts. Not all nuts are healthy. And lean proteins. So if you're thinking about animal sources, you're thinking about your poultry, like your chicken, turkey, and then, of course, fish, which is fantastic. Limiting the amount of red meat that you're eating, and, of course, processed foods, like I mentioned in the previous slide. So how do you determine, this is all great, I have to eat fruits and veggies, but, what veggie should I choose? How should I, use these in combination to form a meal? So when you're thinking about your vegetables, think about your leafy and your fibrous vegetables, and then you have your crunchy and your starchy vegetables. So with your green leafy vegetables, you can eat as much as you want, like celery and spinach and lettuce, iceberg lettuce. You can eat as much as you want. They don't really have a lot of carbs. And then you have some which are also fibrous in nature, but they have a little bit more carbs, like your cauliflower, Brussels sprouts, peas, broccoli, and so forth. And then you have your crunchy vegetables, which have a little bit more starch, a little bit more bite in them. So you have potatoes, your yams, but they have a lot more carbs. So you want to aim for these crunchy vegetables here, which are healthier alternatives. So your onions, your carrots, beets, radishes, mushrooms. So these are vegetables that have less carbs, healthier alternatives with that substance that you're looking for that can be found in a potato or a yam, but it's a good substitute. In terms of your fruits, they're low-sugar fruits naturally, and they're high-sugar fruits. So you have your pineapple and your mangoes on the high-sugar side, and then on the low-sugar side, essentially you have all your berries. And not only are they low-sugar, but they're low in carbs. So your blackberries, blueberries, strawberries, raspberries, these are great fruit sources as part of your diet. And then even within your high-sugar fruits, there's some that are better than others. Grapes, are just pure sugar. I mean, you might as well have citrus fruit instead of it. Apples, peaches, these are higher sugar fruits, but healthier than having a banana or having grapes, okay? Or a mango. In terms of your nuts, so a lot of the times people think, at least in my culture, like people love cashews. They're really expensive. They're like, that's what you want in all your desserts, but they're terrible. You might as well chew on a stick of butter instead. But healthy nuts include your walnuts, almonds, chia seeds, less so peanuts and hazelnuts, but Brazil nuts, actually. This was news to me a few years ago. They're actually a very healthy nut. They're not truly a nut, I guess, but they're very healthy, as well as chia seeds, walnuts, pecans as well. And then your pistachios, pumpkin seeds, not as good. And you want to aim to have about 3 servings of these per week. In terms of the fruits, 2 servings a day. Vegetables, 3 servings a day. In terms of your meats, like I mentioned, prioritize your lean proteins, like your white meats. Fish, whether it's white fish, whether it's fatty fish, it's great for you. Chicken, particularly if it's skinless, or turkey, that's great for you. Eggs are a wonderful source of protein. They actually have the potential to facilitate weight loss because they're so rich in protein. They make you feel full, and they have great nutritional benefit. And then you want to avoid processed meats, deli meats, and limit, I'd say, red meats to about a day a week, I'd say, at most. And of course, you have, as part of the Mediterranean diet, you have low-fat or skimmed fermented dairy. So your low-fat skimmed milk, cottage cheese, Greek yogurt. You want to have about a serving a day. And then your beans, legumes, lentils, about 3 or more servings per week. So overall, if you think about all these things, what should your plate look like? I've mentioned all these different food groups, but generally speaking, if you're making your dinner plate, and this is a model that has been, this link is from Harvard, but I think there's a similar Canada Food Guide plate, which is almost identical to this, but this picture just looked a little bit better. Essentially, half your plate should be predominantly your salad. Like your vegetables, maybe have a little bit of fruit on the side, but predominantly your vegetables, prioritizing your green leafy vegetables. If you want a little bit of crunch, not potatoes or yams, but more like beets or things like carrots, radishes, and so forth. So that's 1/2 of your plate done. The remaining half, so in a quarter, is your whole grain. So your whole grains include things like brown rice, quinoa. If you don't like brown rice because they're difficult to make or difficult to boil, white rice, or do you choose parboiled rice? Parboiled rice is actually a better alternative to traditional like jasmine or basmati rice. But whole grains are things like your brown rice, quinoa, farro, all these kinds of things. And then in the final quarter is your healthy protein. So your fish, your chicken, your turkey, whatever you choose. Or if you decided to have legumes that day as your protein, or chickpeas, that's a good option too. And there's black coffee, not only to prevent the development of fatty liver disease in those at risk, but in those individuals who have fatty liver disease, the likelihood of you progressing is actually lower if you drink caffeinated black coffee. And the reason is mainly the caffeine content. That's what it's attributed to. Why black coffee? Because if you add the creams into it, then that kind of defeats the entire purpose of having something that's supposed to limit the amount of fat accumulation, and no added sugar, of course, as well. What's the magic number? How much should I drink? If you look at this one study, they found that if you drink 3 or more cups of black coffee per day, caffeinated, not decaf, it can reduce the stiffness of your liver, make it more soft and squishy, which is a surrogate for less fat in the liver. Now, if you have a lot of heartburn-related issues, arrhythmia problems, probably not the best thing to do, but if you follow the Mediterranean diet, or if you like black coffee, good for you. You should continue it. It's probably good for your liver. Now, in terms of the other piece of lifestyle modification, that's physical activity or exercise. Now, generally speaking, most of the data, when you think about exercise, you have aerobic exercise, meaning exercise that gets your heart rate going, gets your heartbeat up. And those are things like, running, jogging, swimming, dancing. So all these different things that you can potentially do. And generally what we recommend is that you want to engage in about 150 minutes per week at minimum. Now, some people probably don't exercise at all. So that doesn't mean you got to go to 150 right away. Always start low and build up to it and go slow. So aim for 150 minutes per week, and your body will tell you how much you're able to tolerate. And of course, we're all very busy, and you have to make time for yourself to do exercise and so forth, but it's important for your overall health. And what we recommend is moderate aerobic exercise. So what does moderate intensity mean? It's a very relative term, of course. So just to give you an example, so moderate intensity would mean that on a scale of 0 to 10, you're running at around a 5 or a 6. So as an example, if you were to go on a brisk walk or a jog with a friend or a colleague or a partner, you would be exerting yourself enough that you would be able to just talk to them. You wouldn't be so comfortable that you could sing along with them. So, you'd be that breathless that you could just but not sing. So you can't just be doing a very light stroll, but you have to push yourself a little bit, but you don't want to do it so hard that you cause an injury or so forth. Now, if you have issues in terms of joint problems, osteoarthritis, for whatever reason, you can't go on the treadmill, you can't do certain exercises, you hate water, so you don't like swimming, there's also benefit in doing resistance training. So that is muscle strengthening exercises. So these are things that will improve the strength of your muscles, will increase muscle bulk. So things like using weights, standard things like using your own body weight for push-ups, sit-ups, and so forth. Resistance bands, you're watching TV, you have a little rubber band at different strengths, and you're doing a little bit of bicep curls that way. And 20 to 30 minutes, 2 to 3 days per week, reduce the amount of liver fat and also improves insulin resistance, which is the driving force behind why all these metabolic changes are happening. We spoke about weight loss drugs. So unfortunately, there's no NASH-specific or MASH-specific drugs that are out by Health Canada, but there are drugs that are approved for weight loss. And you can see here, I've put it in a tabular form in terms of which drugs are available and how much weight loss they have the potential to carry on average. So one is orlistat. This is a pill that initially came out by Lilly. It acts by inhibiting gastric lipase, so it basically prevents you from absorbing fats because it doesn't digest it. It only causes about 3% weight loss, so it's not great. And then you have a whole host of different drugs here, which I won't go through the details, but you can see that some of these can give you modest weight loss in the 5 to 8% or even 10% range. And then, of course, we come to everyone's favorite, Ozempic. Everyone's talking about it. And then, of course, is Mounjaro. Unfortunately, at least if you're living in Ontario, up until about February of 2024, it could be prescribed, but now the Ontario Drug Formulary is mandating that physicians need to validate that whoever's getting Ozempic, if they're going to pay for it, you have to have diabetes. Otherwise, you have to pay out of pocket. And if you pay out of pocket, it starts off at around $218 per month, and then as you're escalating the dose, it ends up being about $536 a month as you go up, because it's a pen, it's an injectable, and you're given a certain amount, and as you're increasing the dose, you're using more and more. So, and that is a pretty steep amount that you have to pay. But believe it or not, some people have tried everything. They've done extensive lifestyle modifications. They've gone through the arduous task, and they just can't lose the weight. But if you have diabetes and you're overweight or obese and you have fatty liver, talk to your doctor that you may benefit from not just metformin, but potentially going on Ozempic, which will control your blood sugars better. It's better for your heart. It's better for your kidneys. It will also reduce liver fat. And then, of course, is Mounjaro, which is also a diabetes drug, has been shown in the literature to cause even more significant weight loss in the general population, about 21%, which is very significant. In MASLD patients, close to about 15% or so. And the price for this is actually a little bit less than Ozempic. And of course, this is also approved right now. If you don't want to pay out of pocket, you need to have diabetes for this. But most likely, the first drug that's going to be approved in Canada for MASH is probably going to be Ozempic at this point, just based on the data that's come out in the last few months. And then, of course, you have to control the driving force that's causing or that's facilitating the development of liver fats. If you have diabetes, make sure you have a controlled blood sugar. You want your hemoglobin A1C to be less than 6.5. If you have high cholesterol, you want to make sure that your triglycerides, your LDLs are all within an appropriate level. There's a whole family of drugs called statins. So some of you may know about rosuvastatin, atorvastatin, or Lipitor, or Crestor. A lot of people shy away from using this, and by people I mean primary care doctors or family doctors, because there is a potential that they can cause liver injury, but usually it's very self-limiting, and a lot of hepatologists are now advocating that please use statins for fatty liver disease because they provide much more benefit, and the risk that you're going to have a severe adverse liver reaction is very, very low. If you have high blood pressure and you have fatty liver disease, you want to make sure it's tightly regulated, less than 130/80. And of course, you also need to assess for something called sleep apnea. So sleep apnea is directly increased risk associated with fatty liver disease and also obesity. A quick way to determine if you have sleep apnea is ask your partner, hey, do I snore? And hopefully they'll be honest with you, or they'll have the courage to be honest with you that, yes, honey, you do snore. But that is a quick test, and then based on that, you talk to your family doctor, and they would then do a questionnaire to determine whether or not you have sleep apnea or not, and further testing would ensue. I promised that I'd talk to you about the cancer risk in patients with MASLD. And so the data that came out about 6 years ago showed that in individuals who had MASLD, they actually had almost a double risk compared to the general population of having liver cancer, uterine cancer, stomach cancer, pancreas cancer, and colon cancer. So almost double the risk of the average population. They actually found a signal that there was also an increased risk, maybe not as much as double, but for other cancers, including prostate cancer and ovarian cancer and breast cancer. So it's important that if you have MASLD, given this inherent risk of developing solid organ cancers more so than the general population, it's important that you stay up to date on your age-appropriate cancer screenings that are recommended by Cancer Care Ontario. So if you're female, sexually active, 25 years and older, make sure you go for your pap smears. That's usually every 3 to 5 years. If you're 50 years of age and a female, you need to make sure you're having your mammograms. Make sure you're having your colonoscopies. Same thing goes for males. Have your colonoscopies. Talk to your doctor about prostate exams or using PSAs. And then if you're a smoker or have been a smoker for about 20 years, and you're between the ages of 55 to 80 years, consider lung cancer screening. And that is mandated by Cancer Care Ontario, and they'll pay for it. You should get a CT scan of the chest. So these are just some of the things that it's important if you have fatty liver disease. Don't just worry only about the liver. You got to think about your blood sugars, blood pressure, cholesterol, and cancer screening as well. In terms of MASH-specific drugs, like I mentioned, there's no drugs that are available in Canada as of yet. There's only one FDA-approved drug, that's resmetirom. It doesn't seem like they've applied for approval in Canada, but I'm very glad that Mike has started this petition. Please do sign up because it's important that we have our liver disease-specific drug. Certainly do talk to your family doctor, and I've highlighted the ones here with asterisks, and where I practice at LHSC, we are participating in recruiting patients for clinical trials. These are some of the drugs where we have either participated in the past or are actually going to be recruiting patients for these trials as well. To manage a lot of these things, it becomes difficult to do it on your own. There's a very limited amount of time that your family doctors have to address all of these different pieces that are associated with your fatty liver disease. Understanding that a condition like this, which is multi-pronged, it requires a multidisciplinary effort. We spent about 2 years after I moved here from the US, actually 2.5 years, to come up with this idea where we need to have a one-stop shop where patients who have fatty liver disease need to have meaningful discourse and conversations with hepatologists, need to have access to a dietitian, a physiotherapist or exercise physiologist, in addition to having the ability to have a FibroScan done and also be able to have access to clinical trials. What we've also added to this is also a behavioral medicine piece. So a lot of people who have fatty liver disease also have anxiety, depression, eating disorders that never really comes to light because they have a lot of other medical problems that unfortunately take priority. And a lot of those things, those underlying behavioral disorders can actually drive, and all of these emotional disorders can drive poor eating habits. So we're affiliated with the Behavioral Sciences program at Western to be able to identify individuals who have fatty liver disease who may have or may be at risk of having anxiety and depression. So we're happy to have set up this clinic. So please do speak to your doctors if you're interested. So it's only been almost about a year now since we launched this. So. And I think hopefully more and more programs across the country will be building towards such a model. So take-home points. I know I've spoken for quite a bit now. 1 in 4 Canadians have MASLD, and unfortunately that burden is only on the rise. If you have diabetes or pre-diabetes, if you're obese, or if you have hypertension and dyslipidemia, but you're not obese or diabetic, ask your doctor about screening for MASLD. If you have MASLD, ask about fibrosis assessment via blood work and elastography that may require a referral to a liver doctor. Try to achieve 10% weight loss. Consider the Mediterranean diet. Start implementing changes where you can incorporate exercise into your lifestyle, particularly aerobic exercise. And if you have diabetes, talk to your doctor that how can I use medications for my diabetes that can help me lose weight as well, such as Ozempic or Mounjaro. And then, of course, if you have the opportunity, consider enrolling in clinical trials for new drugs that are on the horizon. So thanks so much.